If you are going for CAPF and AMC interviews, prepare these questions at least.
So first I want you to
Oh,
speak
okay.
on snake bite.
Okay. About snake bite.
Of course,
All
yes.
right, sir. Yes, sir. Snake bite, when the patient comes with a history of snake bite, first what you have to do is make sure that the limb of the patient is immobilized, and you have to reassure the patient. So after that, you have to check for any local reaction on the site. So if it is there is a difference between the different types of snakes that is found in India. So if it's a viperoid bite, that means that it is a hemorrhagic manifestations would be there. On the bite site, for a viper bite, there can be local reaction like bleeding marks, or bleeding might be there, and there will be edema. So all those signs are suggestive of a viperoid bite. So if it is a viperoid bite, then I'm sorry. So that is a viperoid bite, and if it's a neurotoxin, there are neurotoxic snakes include cobra. So all that suggests a neurotoxic bite. So that means the symptoms of the patient would be neurological symptoms like ptosis would be there, or any other neurological deficits. So that means that's a neurotoxic snake. And if it is a myotoxic snake, that means mostly it will be sea snakes are mostly myotoxic. So if it's a myotoxic snake, then that means a patient would have the myotoxic symptoms, which is muscle pain, rhabdomyolysis. So the urinary output of the patient would be reduced. So we have to, if the patient is showing such symptoms, then that means it's a myotoxic bite. However, it does not help since we have only one type of anti-snake venom in India. Even if we differentiate, it is going to help in administering the ASV immediately. It won't help. It can help in categorization between a dry bite and a poisonous bite. That's it. It's not going to change our mode of management. So after reassuring the patient, you can check for these symptoms in the patient, and then depending upon the symptoms, you also immediately when the patient comes, you also have to take the blood of the patient in a vial, so that we can check for whole blood floating time. So after symptomatically assessing the patient, the investigations done are whole blood clotting time. You can also send for PT-INR and basically PT-INR and a whole blood clotting time. And then if at all there are any indications for administering the anti-snake venom, that is if the local reaction is severe, if the edema is crossing one joint, or if there is ptosis for the patient, that is neurological signs like ptosis, etc. is there, then you can start immediately. You have to start administering the anti-snake venom. Okay. And the venom that is given, the ASV that is given, you can give 10 vials of ASV, and that is given over 1 hour. That's what we do in the hospital. It's given within 1 hour, 10 vials you can give. And after 1 hour, you have to again clinically reassess the patient, and you also have to keep serially monitoring the blood parameters as well. So depending on that, along with the ASV, you have to also administer injection Avil, injection hydrocortisone, 200 mg you can administer hydrocortisone, and you can also give a dose of shot of Phenergan. So along with since the reaction of the ASV can be bad sometimes, so it's better to administer these 3 drugs along with the ASV.
Wonderful. Excellent. Now, one good news for you want to discuss. As third boy doctor who has got selected was Abhishek, and I got the news that today one more candidate, like 4th candidate, has got selected for ASC from PD classes. It's a good news for all of us.
Oh, nice.
Again, I'm going to ask you one common question, because I have seen that these are the common questions which are being regularly asked. Like, introduce yourself. This is very common. Snake bite is very common. Now I'm asking you another question, which is quite different from your studies. What qualities would you expect from your juniors, nursing staff? So what would be your answer? Try, please.
The qualities that I would expect from my juniors. The nursing staff. Sir, I want I would expect the nursing staff working along with me to be dedicated. And one thing is dedication. Second thing, that they should know their jobs and they should be very quick at what they're doing. That is the second thing that I would expect them to do. And third thing is that I would expect them to be
Yes.
mainly these two things.
Okay, no worries.
I want them to be quick and I want them to be dedicated.
No problem.
Those are the two things.
You are trying your best. Now today I'm giving you the questions which are asked on 22nd December 2021 by Board 3. Like yesterday the questions which were asked, today I'm discussing with you. Now tell me,
Okay.
what is acute appendicitis? Speak on this.
Sir, speaking about acute appendicitis, it's an inflammation of the acute appendicitis is an inflammation of the appendix.
It's a very common, because itis word itself says inflammation. Something more, like if you go in depth, what we can speak if such a topic is given to us.
So patient presenting with acute appendicitis would usually the clinical features, like patient would be a young patient, it's more common amongst the younger patients, and the patient would present with acute abdominal pain and vomiting, and those are the symptoms that the patient can present with. And when we examine the patient, mostly there will be a McBurney's point tenderness. So that is a sign that can help us clinch the diagnosis. But it's not necessary that all patients have the McBurney's point tenderness. The tenderness can radiate to the left iliac fossa as well, not just in the right iliac fossa itself. When a patient with abdominal pain comes, you can send for investigations. First of all, you can do a complete blood count. If at all the patient does have appendicitis, so we have to. It's an acute abdomen case, so we have to differentiate between appendicitis and pancreatitis. Sending for pancreatic enzymes will help us in serum amylase and lipase will help us in differentiating between the two. And you can send for a complete blood count. You can send for a urine analysis in order to rule out UTI. And if the patient is sick, then you can keep the patient. The management is that you can keep the patient nil per oral. You have to administer IV antibiotics and IV fluids. And you have to wait for the and also analgesics, IV analgesics, and you have to wait for the pain to reduce. And mostly the pain will reduce, and after keeping the patient nil per oral, and you can reduce the infection that is there, and give a general surgery consultation. And depending on what the surgeon says, you can either admit the patient or you can send the patient home. But if it's an emergency, like if it's a burst appendix or something like that, then you have to immediately take up the patient for surgery. So then for that, you have to do a pre-surgical evaluation and immediately shift the patient to the OT for surgery.
Enough. And now speak on acute pancreatitis.
Yes, sir. Acute pancreatitis is another cause for acute abdomen, for a patient presenting to the emergency with acute abdomen. For acute pancreatitis, usually in the south we see because of in alcoholic patients, so middle-aged patients who are alcoholic present with acute pancreatitis. And for acute pancreatitis, usually the pain is epigastric pain. The clinical features are that the patient presents with an epigastric pain which is radiating to the back, accompanied with vomiting. And if such a patient comes to us, we can immediately again keep the patient nil per oral, give IV antibiotics and IV fluids, and then send for investigations. We send for serum amylase and lipase in order to check for the pancreatic enzymes. And if at all it's pancreatitis, then the enzymes will be elevated and we will get the diagnosis directly. And within a few hours or within 1 or 2 days, the patient would get symptoms. We have to admit the patient. And within 2 days, the symptoms will get settled because we are keeping the patient NPO and we're giving IV antibiotics and fluids.
Okay. How is gastric lavage done?
Sir, gastric lavage, okay, how is it done? Practically, okay, fine. So that we insert a Ryle's tube, and after inserting the Ryle's tube, we have to connect the Ryle's tube to fluid to 500 ml NS. We can connect it for and immediately give a stomach wash, and that is how it is done.
And there is a question on management of head injury. So would you like to speak something on this?
Sir, head injury, I'll say what we broadly do here, sir. For somebody who's coming with a head injury, we have to follow the acute trauma life support protocol. So a patient who comes with head injury, mostly the most important thing is that we have to stabilize the C-spine, because mostly the patient with a head injury can have a cervical spine injury also. So first step is that we stabilize the cervical spine by giving a cervical collar, and we stabilize the spine, and then we go for our airway, breathing, circulation, and disability, ABCD management itself. And so after stabilization of the spine, we make sure that we insert two large 18-gauge cannulas can be inserted, and post that we can push in fluids. If at all the patient is in hypotension, you can push in fluids. And immediately, if the patient is bleeding, because bleeding can be there, and we have, for controlling the bleeding, we have to give Trenexa 1 gram over 10 minutes is what is given, and then 1 gram over 8 hours. So Trenexa can be given for controlling the bleeding. So that is airway. Breathing, we have to check whether the patient is having any kind of pneumothorax or any cardiac tamponade or something like that. So breathing, airway breathing, circulation, and the disability. For head injury as such, after stabilizing the C-spine, after the cervical spine, we can send the patient for a NCCT, CT brain, so that we can rule out any hemorrhage in the brain, that is SDH or SAH or EDH. So all these three can happen in head injury. And another thing is that we have to, the secondary cause, the secondary injury, that is first primary is hemorrhage, and the secondary will be raised intracranial tension. So if there is raised intracranial tension, then you have to take steps to reduce the intracranial pressure. So give oxygen to the patient, and then you have to give IV mannitol, which will reduce the central venous pressure. So IV mannitol can be given, oxygen, IV mannitol, and the fluid therapy I already said.
Okay.
That is what we usually do for.
There is a question on vaccine vial monitor.
Vaccine vial monitor. Sir, I'm not very sure about vaccine vial monitor. I only know that there is a vaccine vial monitor for every vaccine that comes. It is to check whether the vaccine is usable or not.
Okay.
So depending upon there is a circle and a square. So depending upon whether I think when it's black or something, then you cannot use the vaccine. I'm not very sure about that.
Doesn't matter. We'll prepare later. Accordingly, we'll give you time.
Yeah.
There is a question on test on water quality, even without any facility with naked eyes also.
Yes, sir. These two questions, community medicine questions,
Yes,
I'll have to check, sir. I do not know.
And what about immunization?
Yeah, immunization. Immunization for the children, no, like National Immunization Schedule.
Yes.
Yes, sir. So, immunization schedule, there is at birth, you give, so that is what you want, no? Like
actually, what is happening, there is a question which has come yesterday from AMC, from one of our student only, that is based only immunization is written. So accordingly, I think they may have given only the word immunization. Then we have to speak.
Yes, sir. It must be immunization schedule itself.
Maybe.
So the immunization schedule in India, at birth, when the child is born, you give a BCG vaccine, you give OPV, and you give hepatitis B. and then at 6, 10, and
Is
14
it
weeks.
only with the child, or like nowadays also we are getting vaccine? Is it also immunization or not?
No, sir. In the
This is
national
different.
immunization schedule, yes, sir. The immunization that we are getting is COVID immunization, no? So that's
Yes,
why I got a
yes,
little
yes,
confused.
yes. Then it must, if
Yeah.
they want to ask about COVID, then they would have written also. Tell about COVID immunization, isn't it?
Yes, sir. Yes, sir.
Okay.
So this is national immunization schedule.
See, one different
that is
question is
followed
there. No problem. If you know, then okay. Just I
Okay.
want to give you the feedback. There is another question which is quite new. What do you think of the cons in your both? Like there are two words, pros and cons, advantage and disadvantages, good and bad. So what are the pros and cons? Here the question is, what do you think are the cons in your both?
in my boss. You mean in the boss with whom I'm working right now?
You can use, you can even with the seniors and with your people, those who are working seniors, anybody.
Yes, sir. So the cons that I felt personally, one thing is that many of the people are not updated. With the latest, medical science is ever evolving. So
Okay.
many people are not updated. So that is one thing. And the second thing, lack of empathy.
Okay. There is a question, HAPE, HEP.
Yes, sir. That is high altitude pulmonary edema. So I'll have to read up on that. We
No
don't
problem.
see those cases here, no? It's like in Kashmir and all, you get, because of the high altitude, you get some breathing difficulty. That's pulmonary edema. So I've never seen such cases.
No
so
problem.
I'll
Go
have
through
to read
this.
up on that. Yeah.
Because as you know also, this is a question was asked even from one of your friend only.
Yes, sir. Yes, sir.
And what about
Yes, sir.
intubation?
Yes, sir. Intubation, sir, with just the word intubation, I don't know whether they mean like, the steps of intubation. I don't know what they mean by that. But intubation is the procedure that we do when you cannot, breathe. Like that is when the GCS indications for intubation is like when the Glasgow Coma Scale, that is GCS score is less than 8, or if the patient's saturation drops to less than 80%. Or something like that, then we intubate the patient. So intubation is done by using a laryngoscope.
Okay. Today our Dr. Dinesh has got selected.
Oh, okay.
There is again question, ethambutol. There is a question on this. Ethambutol.
Yes, sir. Ethambutol is a drug that is used for TB.
Okay.
Yeah, it is used in the primary management of tuberculosis. So tuberculosis regimen is 4 HRSD plus 6 HRE. So 4 HRSD means isoniazid, rifampicin, ethambutol, and streptomycin. So ethambutol is one of the main drugs that is used for TB, for management of TB.
Okay.
And the main side effect of ethambutol is optic neuritis. So these are the two things that I know about ethambutol.
There is another question, duties of MO. I think medical officers.
Yes, sir. Duties of a medical officer, if it's a government hospital, then the medical officer has to see usually would be posted in a casualty, and the medical officer has to see all the emergency cases that come to the casualty. They also have to deal with the medical legal cases that come, like assault, rape, abuse, and all those things. And third thing is the auditing that is there in the emergency department. So the officer also has to be a part of that. Then if it's a secondary hospital. If it's a primary, if it's a PHC, then the medical officer also has to take care of the health of the entire community of that area. So the medical officer also has to go for field visits, and immunization days will be there. Those days the medical officer will have to be in charge of the immunization. So those additional duties will also come if the posting is in a peripheral center.
Okay. There is another question, that is your strengths and weakness.
Yes, sir. So my strengths are that I'm a very confident and adaptive person. So I feel like I can I can adapt to any situation that you put me in, and those are my strengths, and my weaknesses are once I started working, I feel like I haven't given too much importance to physical activities, so I should get back on track with exercise. One thing, and second thing, I feel that sometimes I get too much involved in my work, and I'm very workaholic, and I feel like I need to keep a balance. So that is the second weakness.
Next question is very interesting, doctor. You will definitely love to answer.
Yes, sir.
How do you find your sir, PD classes? Manoj Sharma sir.
Sir, you have been very, very supportive since the beginning. Like, what stands out the most is that you are very cheerful. So you made me very comfortable from the beginning itself. So that is one thing that I want to tell you. So
Okay. Now come on. We'll have this session. Next session.
Osteoarthritis is most common joint disease. Joints involved are distal interphalangeal joints, proximal interphalangeal joints, and first carpo-metacarpal joints. Osteoarthritis is basically of two types, primary and secondary. Primary are the idiopathic cases, and secondary are the cases caused by trauma, overweight, or avascular necrosis. Clinical features of osteoarthritis is pain in joint and decrease in movement of joints. Radiological features include decrease in joint spaces. For treatment of osteoarthritis, we can use physiotherapy or braces. We can use non-steroidal anti-inflammatory drugs like acetaminophen, COX inhibitors, cartilage protectors like chondroitin sulfate or glucosamine. We can use lubricants like injection hyaluronidase. Surgical treatment include joint replacement and high tibial osteotomy. Thank you. Rheumatoid arthritis is autoimmune condition in which body's own immune system destroys the tissues of joints. Rheumatoid arthritis presents with complaints of pain in joints of wrist, metacarpophalangeal joints, and proximal interphalangeal joints. Bilateral and symmetrical involvement is seen in rheumatoid arthritis. Deformities such as swan neck deformity and boutonniere deformity are commonly seen. Flexor tenosynovitis is the hallmark feature of rheumatoid arthritis. Diagnosis is made by MRI hand, RA factor, and anticyclic citrulline peptide antibodies. X-ray shows decrease in joint spaces. Now coming to treatment, we can treat the rheumatoid arthritis by giving methotrexate once a week dose. If the patient is unresponsive to this therapy, we can use triple therapy, which includes increased dose of methotrexate, sulfasalazine, and hydroxychloroquine.
So I would like to share some questions so that you can tell the other students also. So I was asked by board 2, firstly about my name, then to tell about the college name, and thirdly they asked me about CPR, the dose of epinephrine, adrenaline used in CPR. Then they asked me about anaphylaxis, the drug of choice. This specifically wanted to hear epinephrine, and then they asked me about dengue prevention, what measures can be taken, and they asked me measles vaccine, and yes sir, these were the questions asked.
Hi, I'm Dr. Pallavi. I had joined Manoj Sharma sir's PD classes for my SSC interview. I still remember my first day where I had called up sir and told him that I have my SSC interview. Sir just said one thing, "Don't worry doctor, we'll take care of everything." And then my classes began, and his energy is so amazing and uplifting that by the end of the session, you feel so good about yourself. Sir took care of every little thing about how to approach to your interviewer, how to sit and how to speak. Every little thing about body language made me realize that those minor details were also so important during an interview, apart from academics part. Sir guided me throughout my journey, and I would like to thank you, sir. I would recommend everybody, whosoever, for any kind of interview to definitely take guidance from sir's classes and crack their interview.
pneumothorax. So there are different types of pneumothorax. First is a simple pneumothorax, for which you don't really need to do needle thoracocentesis. You can just do an IC tube insertion if it is indicated. Next is a tension pneumothorax. Tension pneumothorax is pneumothorax with rapid hemodynamic changes. So the conditions that causes a tension pneumothorax, one can be a pulmonary laceration, or which can occur due to any penetrating chest wall injury. So when such a injury occurs, what happens is that there is air accumulation into the chest wall, and there is one side, it forms a one-way valve, and there is collapse of the lung on one side, and there is a hyperinflation of the lungs on the other side. So this causes a mediastinal shift, and there is compression of the heart, and this in turn causes hemodynamic changes. So the patient comes with clinical features like increase in respiratory rate, and also there is decreased cardiac output, and increased raised JVP, and there is also absence of breath sounds, and there is also on percussion there is hyperresonant note. So when there is a patient like this, we have to suspect a tension pneumothorax, and the management is that before the management, the differential diagnosis of this condition is a cardiac tamponade. So in tamponade there is muffling of the heart sounds, and in tension pneumothorax there is hyperresonant note and decreased breath sounds. You can also differentiate it by using an extended fast. That is an investigation here, but mainly it's a clinical diagnosis. So now coming to the treatment mode, treatment of the condition. In emergency, what we can do, it is a needle thoracocentesis. So you insert a wide bore IV needle into the fifth intercostal space in adults, and if it is a child, then you have to insert it into the second intercostal space in the mid clavicular line. In adults, it's a mid axillary line. So that is the emergency management. So emergency management gives us time for a definitive management, and the definitive management is a tube thoracocentesis. So in tube thoracocentesis, what you can do is you can insert an intercostal tube into the triangle of safety, and after insertion of the tube, you have to cover the wound with a gauze piece and tape it on 3 sides. So this is the definitive management of a tension pneumothorax.
Hi, this is Dr. Banu. I had joined Manoj Sharma sir's PD class for my AMC interview, and I must say this course has really been an eye-opener. Only after joining this course I have come to know that there is so much to know about personality development. In fact, I realized that it is not only one's dress and mannerism, but as in-depth study of one's mind and understanding of my own strengths and weaknesses. Over and above, I have learned to view myself through others' eyes. I am a new person now, thanks to you, sir. Sir is a very jovial person. He has a really positive attitude, and he also spreads that positive vibes to his students. I'm really lucky to have him as my teacher. So thank you, sir. That's it.
Good morning, sir. Myself, Dr. Abhishek Pramod Nade. Throughout my college life, I have participated in various sports and cultural activities. I have seen many cases throughout my internship, such as organ phosphorus poisoning and snake poisoning. I like to play badminton and swimming. I stood second from my district and represented my district in 100-meter freestyle swimming. My friends called me a versatile personality and enjoyable nature person. Thank you, sir.
Management of head injury. So in patients with head injury, first of all, we have to suspect a cervical spine injury as well. Therefore, the first step should be to secure the cervical spine by using a Philadelphia collar. And secondly, we would monitor the GCS of the patient and grade the head injury according to the GCS. So if the GCS is 15 out of 15 and the patient does not have any loss of consciousness, then that means it's a minor head injury. And if the GCS is 14 to 15 with loss of consciousness, then that means it's a mild head injury. And in case of moderate head injury, the GCS will be 9 to 13. And if it is severe, then the GCS will be less than or equal to 8. So if it is a mild head injury, that is GCS of 14 to 15 with loss of consciousness, then all you have to do is take a CT, observe the patient, and if the CT is indicated, then only you need to do a CT. You can just observe and evaluate the patient, and then if the GCS is staying 15/15 with no focal neurological deficits and the CT is normal, then that means you can just discharge the patient. So if the head injury is moderate, that is GCS is 9 to 13, then that means you have to admit the patient because the GCS is low now, and then you have to do a CT scan and then monitor the patient, and then you have to serially do a contrast enhanced CT or CCT. And if the head injury is severe, that is if the GCS is less than or equal to 8, then you have to intubate the patient and then take a NCCT if it is indicated. So after doing an NCCT, NCCT will show if there is an intracranial bleed, that is an intraparenchymal bleed, or if there is a intracranial hemorrhage like a subdural hematoma or extradural hematoma or an SAH, all those things, or if there is any skull fractures, all those things can be monitored by using an NCCT, and then you have to further go for the management accordingly. You have to treat whatever condition is there, you have to treat the condition. Mostly it will be a surgical management, and patient has to be taken up for surgery immediately. Also, if it is indicated, then you can start a medication for anti-epileptic medications for preventing seizures in the patient. If there are indications for that, it's not routinely given, but if there are indications, then you can go for anti-epileptics. Yeah. Now coming to the secondary brain injury, that is caused due to raised intracranial tension and cerebral edema, that can be managed by giving adequate oxygenation to the patient, and then post the oxygenation, adequate oxygenation, and then you have to make sure that the BP of the patient is more than, systolic BP is more than 100, and you have to give IV mannitol and make sure that you do not give, you avoid hyperglycemia, so you cannot give dextrose based IV fluids to the patient, and here you can give prophylactic anti-epileptics. It is not routinely indicated, but usually we do give. Yeah, so this is the management for raised ICT in head injury.
I want to see myself as a good doctor in AMC, as army runs in my blood.
I want to work with Armed Forces Medical Services as a successful doctor.
So I would like to share some questions so that you can tell the other students also. So I was asked by board 2, firstly about my name, then to tell about the college name, and thirdly they asked me about CPR, the dose of epinephrine, adrenaline used in CPR. Then they asked me about anaphylaxis, the drug of choice. They specifically wanted to hear epinephrine, and then they asked me about dengue prevention, what measures can be taken, and they asked me measles vaccine, and yes sir, these were the questions asked.
Malaria. Malaria is a mosquito-borne febrile disease caused by malaria parasites, a disease caused by members of the protozoan genus Plasmodium. Humans are infected with Plasmodium protozoa when bitten by an infective female Anopheles mosquito vector. Symptoms may appear within weeks to months or even years. There are 5 species of malaria parasite: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium novelsi. The most common malaria parasite in India is Plasmodium falciparum. Malaria is found in about 100 countries in the world. Maximum prevalence of malaria is found in warm and humid environment and mostly seen in July to November in India. Optimal temperature and humidity for the development of parasite is 16 to 30 degrees Celsius and about 60% humidity. Incubation period of Plasmodium falciparum is 9 to 14 days. Plasmodium vivax is 8 to 17 days. Plasmodium ovale is 16 to 18 days. Plasmodium malariae is 18 to 40 days. The mode of transmission is direct by blood transfusion, indirect by a mosquito vector bite, and congenital, which is rare. Investigations may include thick and thin peripheral blood smear, rapid diagnostic kit such as dipstick test, and optimal tests such as bone marrow smear, complete blood count, total count, and differential count. Differential diagnoses are for uncomplicated malaria are upper respiratory tract infections such as pharyngitis, tonsillitis, and ear infection, pneumonia, measles, dengue, influenza, and typhoid fever. Clinical features include high fever with headache, restlessness, anorexia, diarrhea, arthralgia, vomiting, anemia, chills and rigors, hepatosplenomegaly, convulsions, coma if severe, and typically proximal attack of malaria fever found in three stages: cold stage, hot stage, and sweating stage. Cold stage, fever might be there but person feels cool. The temperature may be up from 101 degrees Celsius to 104 degrees Celsius. The main feature in cold stage is chills and rigors, and there is a weak pulse for half an hour to 1 hour. Hot stage, fever is present with 101 degrees Celsius to 104 degrees Celsius. The patient may feel very hot and there's a rapid pulse of from 2 to 6 hours, which is also known as uncomfortable stage. Sweating stage, there is no fever in sweating stage. The patient is presented with sweats. The patient sleeps comfortably to 2 to 4 hours, and it is also called as comfortable stage. Complications of malaria include anemia, hepatomegaly, splenomegaly, renal dysfunction, meningitis, encephalitis, and febrile herpes. Treatment of malaria according to the National Vector-Borne Disease Control Program includes Plasmodium vivax and Plasmodium ovale can be treated with chloroquine plus primaquine, whereas Plasmodium falciparum and Plasmodium malariae may be treated with artemisinin combined therapy ACT plus primaquine. The treatment of Plasmodium falciparum in northeast India may be done by artemether combined therapy with lumefantrine plus primaquine, whereas in other India it is artemisinin combined therapy with sulfadoxine, paramethane, and primaquine. Primaquine is contraindicated in people with G6PD deficiency and pregnant women. Thank you.
My aim in life is to be a part of the prestigious Armed Forces Medical Services.
I want to see myself as a good doctor in AMC as army runs in my blood.
I want to work with Armed Forces Medical Services as a successful doctor.
अभिषेक, हाँ सर हो गया सर, इसमें क्वालिफाई हो गए,
सिलेक्शन हो गया।
हाँ क्वालिफाई हो गए सर इंटरव्यू में।
वाओ, कांग्रेचुलेशंस अभिषेक।
हाँ थैंक यू सर, थैंक यू सर।
बहुत बहुत बधाई हो, बहुत बधाई हो।
हाँ सर आपकी भी बहुत हेल्प हुई सर, मतलब जो इंट्रोडक्शन था अपना,
हाँ
तो वो बहुत सही गया सर मेरा।
अच्छा, बहुत खुश हुए।
जो मैनर्स जो आपने बताए थे वो मतलब चेयर पीछे लेना, फिर बैठ के नॉड करना, वैसा वो सब किया मैंने।
वेरी नाइस, बहुत बढ़िया इंटरव्यू, एएमसी क्रैक किया, वेरी गुड यार, प्राउड ऑफ यू।
हाँ सर कल फिटनेस है सर, अभी बाकी देखते सर। अभी इंटरव्यू तो अच्छा गया सर, बाकी क्वेश्चंस मेडिकल क्वेश्चन भी अच्छे गए।
अच्छे गए, वेरी गुड।
हाँ सर बस 2 क्वेश्चन से थोड़े डिफिकल्ट थे उन्होंने पूछे हुए, तो वो नहीं आया, बाकी अच्छा गया।
चलिए कांग्रेचुलेशन, बहुत बहुत बधाई।
हाँ सर थैंक यू सर।
Dengue, a mosquito-borne viral disease occurring in tropical and subtropical areas. Those who become infected with the virus a second time are at significantly greater risk for developing it as severe time the next time. Mostly transmitted through bite of the female Aedes aegypti mosquito, 4 distinctly but related viruses cause dengue: 1, 2, 3, and 4. Dengue 1 and 2 gives lifelong immunity to that particular strain. But whether 3 and 1 and 4, a second infection by one of the other strains can risk severe dengue, which is potentially fatal. Laboratory test in dengue fever. Clinical laboratory tests are CBC, WBC platelet, hemocrit, albumin, liver function test, urine check for microscopic hematuria, dengue specific test, virus isolation, and serology. The symptoms of dengue are eye pain, muscle pain, bone pain, joint pain, rash, nausea, vomiting, headache, and fever. The treatment of dengue fever is avoid invasive procedure when possible, unknown if the use of steroid, intravenous immune globulin or platelets transfusion to shorten the duration or decrease the severity of the thrombocytopenia is effective. Patient in shock may require treatment in an intensive care unit. Medical history to be taken, physical examination conducted, laboratory investigations done, confirmatory tests studied. Assessment of the disease phase and severity. Identify the complication and social factors. Decision on management, that whether the patient will be ambulatory in Group A, hospitalization for Group B, and administration to ICU for Group C. Notification for surveillance purpose. Classification and notification to be done. In ambulatory Group A, therapeutic indications are rest of fluid intake, paracetamol for fever, verbal and written instructions to return in event of worsening, daily follow-up and appointment. Hospitalized Group B patient, physical exam, therapeutic indications including reference, hemocrate, administration of isotonic liquids, follow-up and laboratory test. Admission to ICU Group C students, therapeutic indications, resuscitation with intravenous fluid with hematocrit before and after intervention, blood transfusion in event of suspicion of massive bleeding. Now, there is one more thing which happens during dengue is dengue hemorrhagic fever, in which we can see abdominal pain, intestine pain, persistent vomiting, abrupt change from fever to hypothermia with sweating and prostration, restlessness or somnolence. This has to be immediately distinguished